Professor De Hurt, what are the most important studies over the last year?
I've chosen a number of studies in the field of perioperative medicine because this is a very important part of our profession, I should say. And in the field of perioperative medicine, I've chosen one article which looks at the role of the anesthesiologist in outcome of the patients. Then there are a few topics on perioperative medicine where I will discuss the PORS-2 study, more specifically the effects of aspirin or the absence of effects of aspirin. And then we will go a little bit deeper on a new study that has been published on the triple low MAC values, low mean arterial pressure, low anesthetic state, which seem to contradict the previous findings on triple low. And then because cancer recurrency and anesthesia is a very hot topic, I have chosen a few articles, a systematic review on this topic to see if the type of anesthesia, local regional versus regional, will make a difference or not. And then one last study concerning postoperative cognitive dysfunction and the role of anesthesia.
What were the most important findings of these studies?
The first study on anesthesiology clearly demonstrated that the choice of the anesthesiologist in cardiac surgery was related to a better outcome. So if you have an experienced anesthesiologist, you get a better outcome. The problem, of course, is whether this is a real anesthesiology-related phenomenon or that good anesthesiologists used to work with good surgeons. The PORS-2 study actually looked at the administration of aspirin in the perioperative phase in major surgical procedures and found that there is no difference in myocardial infarction, in incidence of myocardial infarction. So what we used to do to decrease major cardiac events with the use of aspirin doesn't seem to be true. And this is and it was associated with a major increase in bleeding problems. So we should not give aspirin anymore, at least according to this study. Another study goes on the triple low. So the group of Dancester published a few years ago a study where they found that association of low arterial pressure, low sevoflurane concentrations, and low BIS values was associated with major adverse events perioperatively. And this new study from the group of Miklos Kirtai did not find any difference in or any association between those three and mortality. And then another study on the cancer recurrency and the type of anesthesia clearly indicated that there is no difference between the choice of anesthesia, local regional versus general, and the risk of cancer recurrency. And then a final study was on the incidence of POCD, which also seemed to be major negative study. So it's a problem of open questions that need to be resolved. It's very interesting that these are mainly negative studies. It clearly underscores the problem, the fact that we need to do much more clinical research related to outcome before we can really start to change dramatically perioperative strategies.
Professor De Hurt, how do the studies you mentioned influence our daily practice?
This is actually a very interesting approach because, you know, we have changed for 20 years now our perioperative approach of the patients with beta blockers, for instance, and now it appears that, like we used to give patients aspirin, for instance, it appears that this makes no difference at all. So probably we will not have to change that much, and we will end up doing things like we used to do them for a long time with a good clinical approach of the patient.
Where do you think should the next studies go? Which issues should be addressed in the future, in the near future?
The question of outcome and the question of perioperative strategies that can improve outcome. We have, with the data from the user study, for instance, a clear indication that one of the major problems in the perioperative setting is the failure to rescue. So we really need to develop strategies that we are capable of identifying patients at risk and really target dedicated medication, dedicated treatment, dedicated monitoring to individual patients that are at higher risk of developing problems.